I now want to look at a related situation, which is the reverse problem. So now we have a lobe of the lung which is being ventilated absolutely fine, there's no problem with that, but the perfusion is now compromised. There's a blockage in the blood supply to that part of the lung, and maybe that's a pulmonary embolism. That would be the most common cause. So what we now have is ventilation which is normal and perfusion which is 0. That puts a 0 in the denominator, and that gives you a ventilation-perfusion ratio of infinity. This problem is referred to as alveolar dead space, and the idea is that we now have lots of alveoli in this damaged part of the lung which are being ventilated, but the gas is not being exchanged at all. So it's effectively dead space, it's not contributing to oxygenating the blood. Can the body do anything about this problem? Well, if you think about what's going to happen to the gas levels in that lobe of the lung, the oxygen levels are going to rise and the CO2 levels are going to fall. It's going to become closer to atmospheric air. It turns out that the smooth muscle in the bronchioles can respond to this changing gas content. And in particular, it's the falling CO2 that the smooth muscle responds to, and it responds by constriction. So we get a little bit of bronchoconstriction here to reduce the amount of gas which is rather uselessly going to this part of the lung where the blood supply is compromised. There's some argument about how important that particular effect is, but it's nice in a way that if it does occur, it's analogous to the hypoxic vasoconstriction that we considered earlier. It's a way of reducing the impact of the problem that's occurred, a physiological way of doing that. Now, what's the problem going to be from the point of view of the patient? Well, the blood that's leaving the normal lobe of the lung is normally oxygenated and the CO2 levels are normal as well. That's okay. And there isn't any blood going past the other part of the lung because of the embolus. You might think that that would be perfectly okay because, of course, what that means is that all of the blood that's going back to the heart is effectively normal blood. Whether or not this is really a problem depends on how much of the blood supply to the lung has been compromised. Obviously, if it's a very small embolus which is only blocking a tiny part of the lung, it's not going to be too much of a problem. But if you're blocking a substantial amount of the blood to the lung, there's going to be quite a considerable problem, and of course, this can ultimately kill you. One of the rather interesting things that happens in this case is that if blood can't reach this particular lobe of the lung, then there's really no choice but for the same amount of blood to go through the rest of the lung. The blood is being diverted through the channels that it can actually still pass through. And you have a rather interesting situation now that the remainder of the lung is being overperfused. There's excess blood moving through it because it doesn't have a choice. And what that means is the ventilation-perfusion ratio of the rest of the lung can actually move in the opposite direction. Now we have excess perfusion here, so the ventilation-perfusion ratio of this other part of the lung can actually be a little bit too low. And that can give you a certain amount of alveolar shunt. So we have the rather confusing situation where a situation which was causing alveolar dead space, in other words, a pulmonary embolus, can actually end up resulting in a degree of alveolar shunt. This effect has been demonstrated to occur experimentally, and it's certainly an interesting theoretical situation from a physiological point of view.